Having many years of experience gained from work with patients suffering from aphasia, apraxia, dysarthria or swallowing disorders, that is, dysphagia, I strive to improve therapeutic programs by implementing new scientific achievements. I have managed to create an APTA-MP therapy program, in which I tested how effective the Syrebo Robotic hand rehabilitation system is. An aging society struggles with many health-related issues. One of the most serious issues as regards the scale and effect is the brain stroke. Upon a stroke, a significant number of patients become disabled due to speech disorders or paralysis. Thanks to the properly planned therapy, it is possible to restore disturbed speech functions to a level that would enable the patient to function independently, even in the case of total aphasia. However, this requires a long-term treatment. Studying the brain, learning how it works and about its compensatory abilities, we may get a much wider perspective on the therapy process. The latest brain maps show that the brain is actually more complex than we have previously thought. The new map of the human brain contains 180 separate areas in each hemisphere, including 97 not discovered previously. The scientists of Washington University Medical School in St. Louis, Missouri, David Van Essen and Matthew Glasser, stressed that studying new areas of the brain is a huge breakthrough. The brain was studied not as fragments, but as a whole, which allowed for the creation of new brain maps. Until now, when discussing speech disorders as a result of brain strokes, the main focus has been laid on Broca's area. Recent studies have proved that there are other, unrecognized areas of the brain that may also be crucial to speaking abilities. The Area 55B is an example of such a discovery. Interestingly, this area is located relatively far from the Broca's area, but is in close proximity to the motor cortex, which is responsible for hand movements and motor planning. The location of Area 55B only confirms the long-recognized speech and hand connection. However, an extensive network of connections is responsible for the proper functioning of the brain. Another discovery is the so-called connectome. An extensive network of connections forms itself along with one's life experience gained. The connectome allows people to think, dream, have memories, and to be an individual. It is like a kind of fingerprint, characteristic only to one person. Due to the dense network of connections, there are other possibilities to overcome disabilities caused by brain injuries. It is clear to be seen that each part of the brain is connected to another one, which allows us to have a broader understanding of recovery chances after a brain stroke. As studies have shown, the extremity used more frequently creates an even larger network of connections. It creates new motor areas. Thanks to studying somatosensory evoked potentials, SEP, and motor-evoked potentials, MEP, the plasticity of the somatosensory cortex is best known. Studies on MEP performed on patients who had their extremity amputated have shown that the stump muscles can be stimulated to contraction by magnetic stimulation of larger motor cortex areas than before the amputation. This only proves the extraordinary ability of the brain that can improve itself. On the other hand, however, a patient after a stroke is at risk of having connections that are not used reduced. This is why it is so crucial to have an early and intensive postictal rehabilitation process. Different types of brain plasticity can be recognized. Some are used to acquire knowledge, learn. It is called a memory plasticity. Others are related to the development. The brain's ability to a compensatory plasticity is primarily used in neurological rehabilitation of a patient after a stroke. This involves the brain's ability to control the healing processes in response to an injury. Stroke usually affects older people. A person after a stroke becomes disabled due to physical disabilities such as extremity paralysis, also due to speech disorders that can take different forms: aphasia, apraxia, dysarthria. Another issue appears when discussing patients of senior age: motivation to overcome the effects of a stroke. An intensive rehabilitation, where the mechanisms of brain plasticity are used, is a chance for recovery. Not so long ago, in the 80s of the 20th century, a damaged brain was believed to have no chance for regeneration. The most common communication problems of the patient with the environment are aphasia. It most frequently disrupts the reception of speech and ability to articulate. The patient faces difficulties related to understanding speech, has difficulties in constructing and processing sentences, and lacks words. In the case of dysarthria, the issues are articulation disorders, prosody, intonation, excluding difficulties in planning a speech. In the case of apraxia, which is included in or, depending on the literature, separated from the aphasia, the patient, using their speech organ, is unable to perform correct movement in order to speak. The mouth does not respond to what the brain communicates. This is the most important challenge for therapists. The situation of a patient is particularly difficult because, while thinking properly, he/she does not know how to utter a word. Therapy treatment programs for apraxia usually take many years and does not produce the expected results. Having been working in a stroke unit for many years and providing long-term therapy treatments for patients after a stroke with aphasia, I have noticed a certain regularity. The primary need of the patient is to ensure his or her own independence and to meet his or her basic psychological needs. Patients with lower and upper extremity paresis, speech disorders of an aphasia type, prioritize improvement of mobility of the lower extremity, then the speech, and lastly, mobility of the hand. Mobile lower extremity enables the patient to become independent, for instance, to be able to take care of basic physiological needs, such as using the toilet. These observations are confirmed by the so-called Maslow's hierarchy of needs. The hierarchy's base, at its most crucial level, constitute the necessary needs to keep a person alive. That is, satisfying physiological needs such as hunger, thirst, excretion, sleep, avoidance of cold and heat. Only when these needs are satisfied, a person can proceed to the next stage. The patient even forces the therapist to have the need to be able to walk satisfied in the first place, and then to be able to speak. Only after they are satisfied can the patient notice the disability of his or her hand. Slide 13. It is recommended that the procedure after a stroke should consist of simultaneous rehabilitation of the leg, speech, and hand. Such programs should not be delayed in time. An intensive therapy for all damaged functions enables one to be successful. Prognosis after a stroke depends on many factors: baseline condition of the patient, type of stroke, extent of stroke, comorbidities, complications, age of the patient, motivation of the patient, support from close friends and relatives, accurate neurologopedic diagnosis, therapy in a stroke unit, in a post-stroke rehabilitation unit, continuation of intensive rehabilitation at home. It can last for months or years. The APTA-MP program, as a standard, includes high-intensity classes, every day lasting 7 up to 10 days. The program is intended for the post-stroke patients, after an acute period, hospitalization. The therapy can be started at any time, regardless of the time of the stroke. It includes 2 hours of speech therapy, 2 hours of hand therapy, 1 hour of therapy in hyperbaric chamber, and 2 hours of group therapy once a week. After this period, the patient continues the therapy at home, and after a month, returns to another intensive cycle of the therapy. In the case of apraxia, APTA-MP program aims for speech activation using movement, rhythm, melodic intonation therapy, automatisms, pinxia, graphia, lexia, mirror neurons, fingertips-based therapy, symbolic praxis therapy, group therapy, usually from 3 to 10 patients, and other methods depending on the patient's needs.
Terapii bierze od 3 do 10 pacjentów udział oraz innych metod w zależności od zapotrzebowania pacjenta. Ponieważ obszary mózgu odpowiedzialne za ruch ręki i ruch narządów mowy położone są blisko siebie,
therefore, therapy programs of these two functions were combined. The APTA-MP program was based on a mirror therapy, pinxia and graphia therapy, from the moment when it was possible to do so. Combining these two therapy programs, the hand and speech therapy, allowed the patient to recover faster. Now the hand therapy program was enhanced with a functional therapy using the Syrebo Robotic Rehabilitation System, SRHRS. In addition, patients undergo an oxygen therapy in a hyperbaric chamber. The hand therapy using the Syrebo Robotic Hand Rehabilitation System, SRHRS, takes place in stages. Attention is drawn here to ensure that the patient receives numerous visual, sensory and auditory stimuli. This allows to reprogram the brain, to teach it that the non-mobile extremity starts to function properly. With this information encoded and the movement of the hand actually seen enable the patient to improve his or her motivation and recover faster. The therapy takes place in stages. A few ways of using Syrebo Robotic Hand Rehabilitation System in hand rehabilitation process were provided as an example. During the exercises, a mechanical mode is used, automatic and semi-automatic mode. The therapy is conducted using appropriately fitted gloves that are connected to the device. By using the control glove, the therapist can determine the patient's extremity movement. In the case where the control glove is worn by the patient, it is the patient who can determine both hands' movement. In order to properly program the brain of the patients with aphasia, the presence of a hand therapist is necessary. A patient who shows no signs of cognitive disorders can conduct the therapy on his or her own without close cooperation with the therapist. The first stage of therapy can be conducted after the hand spasticity is excluded or after it is loosened. Both hands work in an automatic mode while the therapist names each activity. Open, close, open, close. Implicitly, I am doing it. The activity is repeated for several minutes. The therapist is the one to take the decision on the movement and asks to alternately open and close the paralyzed hand. At this stage, the patient is asked to perform a particular activity of opening or closing his or her hand. The patient performs the movement with his or her mobile hand and then repeats it with his or her non-mobile hand using the semi-automatic mode. The next stage might be to use the hand functionally, for instance to lift objects. Here, a tube from a special base. The therapist names the work stage one by one. Lift, lower down. An additional difficulty can be to stop the movement up at the top at the therapist's instruction. The therapist names the work stage one by one and gives instructions. Lift, stop, lower down. When the glove is changed to the control one, the patient independently performs the activity asked for by the therapist. Lift your hand up, stop at the top, lower down. This is an independent mode. The effects of the apraxia speech therapy using the Syrebo Robotic Hand Rehabilitation System were noticed much faster than in the previously conducted therapy.
1, 1, 100 lat. Melodie.
La to ta 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 la. La to ta 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 ta. ta 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 ta.
Dobra. Na
The presented video shows the
widać,
patient
że
utters
pacjent
only
wypowiada
embol, ta ta ta, or
lub
lato.
lato.
The patient is unable to repeat even the easiest words, is unable to utter automated sequences, all due to the activation of embols. No dialogue is conducted. The patient answers the questions with one meaningless embol, ta ta ta. After 7 days of therapy, that is, 14 hours of the speech therapy, 14 hours of the hand therapy, 7 hours of the oxygen therapy, and 2 hours of the group therapy, the patient can repeat not only single words, but also sentences. He or she spontaneously produces single words and can answer simple questions. A dialogic speech is already possible, but the patient answers using simple words. There is no storytelling speech, which requires an ability to speak freely.
Pani Darku, co ona teraz robi? Ona sobie coś tam, kanapkę sobie je. Kobieta myje auto. Kobieta myje auto. Panie Darku, kto myje auto? Auto myje ta kobieta. Dobrze. Co ona robi z tym autem? Ona ten samochód brudny teraz
myje.
Dobrze. Kobieta jedzie autem. Kobieta jedzie autem. Kobieta jedzie autem. Co ona robi? Ona szybko jedzie. Czym ona jedzie? Ta kobieta jedzie swoim
autem.
Świetnie. Kto jechał na ryby? Na ryby jechał samochodem ten
Rysia.
Dobrze. Po co on jechał samochodem? On jechał na ryby. Dobrze, na ryby. Panie Darku, i ostatnie pytanie. Czym on jechał? On jechał swoim... Nie. On jechał swoim
autem.
The video shows that the patient has enhanced his or her abilities to utter words. The mouth starts to understand the instructions coming from the brain. It is just the beginning of the therapy, but in the case of this patient during 1 year of rehabilitation, the improvement involved the understanding of speech. However, the speech itself was limited to the embol ta ta ta. The chart shown here presents these functions that have been improved: repetition, spontaneous speech, automatisms, etc. In order to illustrate the progress, videos with the participation of one of the patients receiving APTA-MP therapy were presented. The original aphasia therapy program, APTA-MP,
pacjentów objętych programem APTA-MP
has been proving its effectiveness for 12 years. This program consists of an intensive speech therapy combined with a hand therapy and a hyperbaric chamber. The first significant effects of speech improvement of post-stroke patients with diagnosed speech apraxia appeared after 1 to 2 months of the therapy. The introduction of intensive hand therapy assisted by the Syrebo Robotic Hand Rehabilitation System, SRHRS device, allowed the first therapeutic results to be achieved by the patients without hand spasticity in as few as 7 days. Additional effects include improved hand function and increased patient motivation to continue exercises.
Jakie są wnioski?
As a result of the
wyniku
conducted
przeprowadzonych
studies,
badań
it turned
okazało
out
się,
that a
że
hand
terapia
therapy
ręki
assisted by
wspomagana
the Syrebo
urządzeniem
Robotic
Syrebo
Hand
Robotic
Rehabilitation System
Rehabilitation
device is
pomaga w
helpful
terapii
in treating
apraxii ze
aphasia with
szczególnym
particular
uwzględnieniem
emphasis on
apraksji
speech
mowy.
apraxia. The
Zastosowanie
use of
w
the
programie
SRHRS device on the
Syrebo
APTA-MP
pozwoliło
program
osiągnąć
helped improve
poprawę
speech in a
mowy w
much shorter
zdecydowanie
time
krótszym
than without
czasie
such support.
niż bez takiego wspomagania. Dziękuję Państwu za
Thank you.
uwagę i zapraszam do Polski.